Good morning. Thank you for allowing me to present some of our research and also some of the work that the SAGES Research Committee has been doing over the last few years. The title of the project I'm presenting is the timing of cholecystectomy following cholecystostomy drainage for acute cholecystitis. These are my disclosures, which are not relevant to this topic. Patients with acute cholecystitis presenting either with unfavorable systemic or local or both conditions may be managed with percutaneous cholecystostomy drainage as a temporary measure that's part of the Tokyo guidelines for management of disease. And often these patients will present for interval cholecystectomy for definitive management down the road. It remains unclear what are the clinical outcomes of that subsequent operation. The aim of the study was to identify the effect of timing of surgery following percutaneous cholecystostomy for acute cholecystitis on perioperative outcomes of cholecystectomy. This was a retrospective multicenter study. This was designed by and endorsed by two different surgical societies, SAGES and AAST, and then distributed to their respective research committees for member participation. Adult patients with acute cholecystitis without concurrent common bile duct stones, initially managed with drainage, who subsequently underwent interval cholecystectomy, were the focus of this study. And these were patients who had their surgery in the 3-year period, 2018, 19, and 2020. The primary outcome of the study was the composite endpoint of bile duct injury, reoperation, readmission, image-guided or endoscopic-guided intervention, conversion to open surgery, or death. So any patient who experienced any of the above was deemed as having met that primary outcome. There were 7 clinical sites with 188 patients included. Based on the Tokyo criteria, cholecystitis was mild in 41%, moderate in 47%, severe in 12% of those patients. Surgery was planned as laparoscopic for the majority, 90%. A small number of patients were planned as open procedures, and 6.4% had robotic cholecystectomy. Ultimately, 15 patients had a subtotal resection with representing 8% of the cohort, and 8 of those patients were fenestrating type. 28 patients had their procedure converted to open for 17% of the cohort. Surgery was a median of 65 days from the drainage procedure, and based on that interval and the distribution, we grouped patients into 4 categories in terms of, based on the quartiles of that time interval. So 0 to 7 weeks, 7 to 9, 9 to 13, and over 13 weeks. A biliary injury was noted in 7 patients, which was 3.7% of the cohort. Now, this was a type A cystic duct leak in 5 of those patients. And as you see the distribution per time interval, that rate was highest in the group over 13 weeks. In terms of the primary outcome, 51 patients met that primary outcome, which was 27% of the cohort. And again, as you see the distribution of that throughout the 4 groups, the group that was the earliest surgery seemed to have the lower rate of meeting that composite outcome. Now, when we compared further patients based on who developed an adverse event versus not, there was no difference in the distribution. I don't have this data here. No difference in the distribution of mild cholecystitis or the degree of cholecystitis. No difference in Charleston Comorbidity Index between patients who developed and did not develop adverse event. And multivariate regression analysis was done, and again, the time interval by weeks was associated with the development of that composite outcome, and we see that early group, 0 to 7 weeks, seemed to do better than the very later group. There was really no difference in those in-between groups as we looked at the data. So to conclude, interval cholecystectomy has a considerable complication rate, with 27% of patients experiencing an adverse event, and the timing of surgery can impact procedural outcome. seemingly patients who having surgery within 7 weeks of drainage demonstrated the lowest rate of morbidity. And I want to thank all the groups that participated and the research committee for helping us put that together. Happy to take any questions.